just amazing kind of value for your time. It's Friday and Saturday, 16th and 17th of May. We've just started planning on that. We have a couple of charter members here. Some of the planning committee have left, but Naveen Bish there, he's our program chair, director, and throughout the year, he's the brains behind a lot of these events and programs that we host here, and he keeps us on our toes. Saurabh Tendon there, he's our sponsorship chair, and again, he's going to get very active, looking for our sponsors for our next conference as well as 2014. And we have, who else we have here? Pradeep Madan there, he's our convener, co-convener for TICON 2014. He's going to get very busy working through what's hot, what's coming for next year, and what will excite all of our attendees that are planning to be at TICON. We have Shekhar Gupta here. He's between here and India, spends some time here, and kind of looking at various entrepreneurial opportunities. TI was founded 21 years ago. We at the office here were a small team. I have Ramesh Krishnan there. He's our business development, sponsorship, relationship management. We have Kelsey there at the registration desk helping us with our events and programs. Terry manages all our marketing, so the weekly emails, Terry is responsible for that. Harini is not here, she manages our charter member programs. So with that team, we kind of are well supported by our board. All of them are charter members and volunteers. Our president, Venk Shukla, was here earlier on, had to leave for another event. He's also a volunteer. Rajiv Patel, he's going to be co-chair of content for TICON 2014, a charter member and very involved. So very happy to have you all here. Do come again and look out for our events which are posted 4, 6, 8 weeks in advance. With that, I'd like to introduce our charter member, Dr. Sanjay Kumar. Also, of course, our charter member, Zain, who is supporting us in this program. And Dr. Sanjay Kumar will take it from here, introduce the panel members, and appreciate all of our panel members being here with us this evening. Thanks so much.
Thank you, Raj. My name is Sanjay Kumar. I'm charter member at TI and really very happy to convene and moderate this particular event. How many of you are actually here because you're very, very confused about what healthcare reform is all about and what's happening today? Wow, there you go. So we definitely had the right topic selected, right? So with the rollout of healthcare reform has, I think, come a monumental shift and a change in times in the way that healthcare is actually delivered, healthcare is actually being administered, and the way that healthcare will actually be driven in the future. I think personally, from my standpoint as a clinician or as a past clinician, the day for the consumer in healthcare has actually finally come. Meaning that consumers are going to be that much in the driving seat to basically drive healthcare where it's going to go. And really to enlighten you that much more, today we have actually convened a number of very esteemed panel members that are going to at least help us better understand where healthcare reform is coming from, where it's actually headed, and what it's actually going to do for us. And my job is really, together with you all, is to make sure that we ask all those questions. I don't want to be in the position of asking any questions. If all the questions can come from you, that's a better job for me. But let me go ahead and introduce our panel members. We have a number of them on the panel. Sean Bolton is actually Northern California Director of Sales with Covered California. So like with a number of different states or different programs that have been enacted, California has a program that basically provides a healthcare insurance exchange. And Sean is going to be telling us a lot more when he introduces himself in more detail. We have Larry Liu from Chinese. He is a director of business development and operations with the Chinese Community Health Plans. And believe it or not, this is actually a very, very interesting story, and I'm sure that Larry is actually going to go further into it in terms of how the Chinese Community Hospital actually went about creating a ACO, and through the ACO, literally a plan that is being offered through the Healthcare Information Exchange, Insurance Exchange, and the kind of price points that you're basically able to provide. I think great insights from that. We have Darlene. Darlene is tax director at Hood & Stroud LLP. So all of those wonderful entrepreneurs that are wanting to figure out all the loopholes with the tax codes with Obamacare, you've got the right person on the panel to actually address that too. I don't know about all the loopholes right now, but I'm sure Darlene knows some. We have Michael Gallagher. Michael is actually with Blue Cross Blue Shield of Arizona. And every time I look at Michael, I say, you know what, I've seen this guy somewhere, but you know what? Must be Kojak's look. But we have Michael. And then last but not least, we have Zain, Jeewanjee, who is with Jeewanjee Insurance, founder and CEO, and really founder and CEO for a number of other companies that actually he can enlighten you more on. But the panel that we have literally comes from all aspects of, I think, from delivery of healthcare down to some, the health plans, as well as the insurance exchanges and the broker community. So with that, I would actually like each one of the panel members to not just introduce themselves a little bit more in detail, but also to provide a bit of a perspective to how they see their own entities interacting or working with Obamacare and where Obamacare is taking them. With that, Sean?
Thanks for having me. Good evening, everybody. So, who's all an expert and read the 2,000-page ACA document? All right, one of us? Just me? Half? Oh, we got half from Larry. Oh, we got two. So, our job from Cover California's perspective is the director of sales for the SHOP, which is the Small Business Health Options Program. We're here to help small businesses that they qualify or are eligible to enroll into the exchange. So there's two different sides of the exchange. One's the individual side, and one is the small group side. So our job as the experts in the small group, we also deal with a lot of individual questions. So if you do have some of those later on this evening, I can definitely help you out with those. But from our perspective, we're here to help the enrollment process in the exchange go as smooth as possible. Has anybody heard any hiccups that have happened over the last month or two? So being California as large as we are, I think the last number I think I saw was 35 million people in the state of California. We were so large, we wanted more of a say in what we were doing as the exchanges go. And there's some of the other states, 33 of them I believe, that are on the federal exchange, but in California, we're so big, we're like, hey, we want to have more of a say. We're going to create our own exchange, be an active purchaser in the entire program. And now what we've done is created our own exchange. We've had our few hiccups here and there, but not nearly as many as the federal side, just because they're dealing with 33 different states. So it's a much more difficult task. So we're excited. We open for business October 1 for the individual market. We're going to start enrolling small businesses into the exchange starting for January 1 effective dates. So looking forward to talking to some of you over the next hour and a half about the different options that we have available, and excited to be here. Thanks.
Okay, thank you, Shane. I'm Larry Leung from Chinese Community Health Plan in San Francisco. I'll give you a little bit of background about who we are and how we came to be the delivery system that we are. So Chinese Community Health Plan is actually part of an integrated delivery system. As alluded to earlier, we're kind of like an ACO before the term was even invented. It all started with the hospital, Chinese hospital in San Francisco. As a delivery system goes back to 1899 when there was rampant discrimination in San Francisco and there was no access to modern Western medicine. And so some founders, about 15 organizations got together, built a medical dispensary, then that got burned down in the 06 earthquake, rebuilt it, that outgrew itself, and from that point on, we've had about 3 generations of hospitals that are being developed. Chinese Hospital also operates community clinics, and in 1982, the physicians that were part of the medical staff in the hospital formed their own independent physicians association. So if you're familiar with the term IPA or medical group, that's what they did. Shortly thereafter, they needed to have an entity that did all the administrative health plan type work. So CCHP was formed. In total, we cover about 33,000 lives. Our service area is 1.5 counties. We have a very strong footprint in the Medicare Advantage space. We also have large group business, which is groups 51 and above. We have small group business, and then we also have individual business. And from our perspective, the reason why we're even in Cover California is kind of a no-brainer. We're here because we have a unique delivery system that, quite frankly, shares in a joint risk pool. So it's not the hospitals pitted against the physicians, pitted against the health plan to see who can get the most money out of this pile. It's really how can they work together to integrate care, to make sure that they have a very efficient network, to make sure that in some years when the hospital's not doing as well, maybe the physician group kicks some money back over in a joint risk pool and makes them whole. And as a health plan, we administer the whole pool, so we make sure that it runs efficiently. So that explains why, if you look on Cover California, in terms of one of the lowest cost plans around, we're in that space in terms of the lowest cost. We've also been in plans like Pack Advantage. I don't know if any of you are familiar with Pack Advantage, that kind of came about as the early healthcare reform experiment back in the 90s. It was the HIPIC, which was the Health Insurance Purchasing Coalition, which then migrated to Pack Advantage and subsequently died. And it died because there were not some mechanisms to ensure that health plans that participate in that pool are made whole if they have bad risk. And so some of the requirements in the new Affordable Care Act actually fix a lot of those problems. So as an integrated delivery system, it's not a matter of whether or not we wanted to be in it, we just needed to be in it because we were here to serve the community. But I know there's one question that people are dying to ask me, the question that I get all the time, and the answer is no, you don't have to be Chinese to join our plan. But people think they just by our name. So anyway, I'm going to pass this along.
Thank you, Larry. I'm Darlene Hall from Hood & Strong. And Hood & Strong is a public accounting firm here in the Bay Area. We have offices in San Jose and San Francisco. And we're made up of accounting and tax advisors. Myself, I'm on the tax side. So my perspective on the Affordable Care Act is, as a lot of people know, it's been around since 2010. And so on the tax side, we've been dealing with certain provisions of it since 2010. And there's been additional changes. So we're continuing to help employers, individuals, the businesses comply with the various tax aspects of it, and also to help them take advantage of the various credits and deductions, and at the same time calculate the additional tax that they'll be paying because of the changes with the Affordable Care Act. So we're really here to help our clients and comply with the various tax aspects of it, and anything to advise them on that side.
I'm Michael Gallagher, the bald-headed guy that he thinks he's met before. I don't know about that one. But I do agree with the consumer-driven healthcare perspective, and I think that's what I bring to you this evening. I can proudly say I've been involved in no less than 5 startups in the healthcare industry, and not one of those companies exists today. That tells you a lot about what's happened with health insurance companies over the period of time going through healthcare reform and various different changes. I was also involved, I come from the California market, I was involved in the committee that developed the original idea around small group AB 1672, HIPIC, and those kind of things, seen it from the carrier's perspective, from the inside out. And I can also say is that during the period of time when President Clinton was trying to initiate a small group, or I should say a healthcare reform act, and it was unsuccessful, the insurance companies were put on notice at that time they needed to make some adjustments. They needed to be more cognizant of the fact that consumers needed to know what services really cost and how can they make good decisions. Unfortunately, the insurance companies didn't wake up to that. That costs money. You have to invest in technology and a lot of other things that they just did not address. So now you have healthcare reform, and this is the way you're going to receive your healthcare. And so it's really incumbent on you to really understand how you can best use it. I look at it this way. You can say that change can bring danger, danger brings challenge, challenge brings opportunity. And for you all as entrepreneurs, as business owners, this is an opportunity for you to look at how you really take care of the best asset that you have, and that's your employees. That's your investment that you make. So hopefully tonight we're able to answer some questions to that and, assist you with those questions.
Thanks, Mike. I'm Zain, Jeewanjee. March 23rd, 2010 is when the signature Barack Obama signed the Affordable Care Act. March 23rd, 1983 is when I came in the US with a child who needed medical care, my son. We tried to get insurance for him and we couldn't because he had pre-existing conditions. So when he signed it in March 2010, I was very glad that now somebody would be able to buy insurance when they wanted it. My son actually passed away and we were left with a huge amount of medical bills. So I went and discovered that why is the world's largest GDP at that time does not have a plan to cover foreign nationals that come in this country. So in 1985, there was a company called Seabury & Smith. They're now an Aon company that used to sell medical insurance for foreign delegates. We convinced them to write a visitor's medical insurance plan, and in 1985 we created what was at that time the first medical insurance policy for foreign nationals, a true medical plan policy created. I'm very brilliant, I think ahead, so I already knew that Silicon Valley is going to explode with foreign nationals. No, I knew all that, so I was just sitting in the right place at the right time. I created the product, and Silicon Valley was about to explode with all these South Asians coming in, and they would have their mother come in and visit them for 6 months, and wouldn't have medical insurance. So I was just sitting in the right place. So when Obamacare in March 23rd, 2000 was signed, many people in our community, which is the insurance and the brokerage side, were very concerned that we are making 20% commissions on an individual medical insurance policy. And if Obamacare comes in, we're going to be out of business. So most insurance industry people were very concerned about it, were wary about it, didn't support it. I was right on top of it because I knew what my son and what I went through, I don't think any American should ever go through. Medical care is not you going out and buying your Tesla that burns up in a fire, but it's really a necessity. Covered California, the exchanges, if you look at it, it really is an opportunity and a privilege for Americans now that couldn't afford and couldn't buy insurance can now get it. So you're not bankrupt because you got a $490,000 bill. Again, as I planned it, we didn't know that Obamacare would keep the agents in place. Now, they adjusted the commissions, by the way, on group insurance, they were always 2-3%. Individual commissions, which were 20%, are now going to be 3 to 4%, which is really the way this should be in the first place. And so I'm very excited about Obamacare. We've been supporting it. Our company now ranges, that small business insurance company, which started in '85. We're considered one of the largest brokers in the country. We operate all over the U.S. We have offices all over. We insure people all over in the U.S. We have offices in India and in China. We insure a small startup companies like Cisco. You might have heard of a startup company. Another small company, we do international benefits, Google or something like that, some name, I don't remember the name. Little companies, we do take care of the international benefits. We do countless of other companies, and we're delighted to be on this. I don't know how I fit in this film, but I got in here.
So I have a few questions to ask, and then we'll literally open it up to the audience to ask a few other questions. But there's a misperception, or there's perhaps a perception out there that that Obamacare is only for the poor, or for those in financial difficulty. So from each one of your perspectives, either from the health plan perspective or from the product perspective, can you enlighten us a little bit further regarding what Obamacare is really all about and who it serves?
Sure. So the goal of Covered California is basically to have every Californian insured. We want everybody on some type of insurance plan. If you look at the demographics of California, there's 5.3 million Californians that are uninsured. We need to get to those people. A lot of them don't buy it because they can't afford it. They might have a pre-existing condition, like Zain has mentioned. So we want to make sure we're getting to those people. But we also want to give small businesses another option compared to what's out there in the private market. So we're going to try to, our goal is to negotiate purchasing power, to negotiate with the different insurance carriers and bring choice and hopefully lower cost to the small business employers out in the marketplace. So although the poor is a big part of what we're doing, and if you look at the Medi-Cal market, they're expecting about 1.7 million new Medi-Cal members in the state of California that are going to qualify for Medi-Cal. We need these people covered so they can start being a part of the system instead of everybody else having to take care of them and pay for it, because we're all paying the taxes that pay for this, right? But we want them a part of the program so we can include everybody in the pool and eventually drive the costs down. So that's kind of the perspective from the exchange.
Yeah, let me just add on to that. One of the things we didn't talk about is really what the exchange is trying to do as an instrument of change in California and what's going on in California more broadly. So in California, as Sean mentioned, there are actually two exchanges, one for employer groups. So if you have your employers between 1 to 50 employees and you want to buy coverage in the exchange, you can send your employees there. You pick a metal tier and you can pick from among the typically about 4 different plans. So that gives a consumer choice of what plan to pick, so you don't have to worry about it. If you try to do that now on your own, you're going to have a tough time finding 2 health insurance plans that are willing to offer you coverage. So Cover California helps do that on the employer group side. The next grouping is really the individual. So these are folks who don't have employer group coverage and don't have qualification for some government program. Actually, let me pause there for a second. So on the government program side, you guys may or may not be aware that in the state of California that there's a thing called the Medi-Cal expansion. So instead of being at 100% federal poverty level, it goes to 138% federal poverty, which is a massive expansion of Medi-Cal. So a lot of folks who are earning for an individual, it's slightly less than $15,000 a year. So they can qualify for pretty much free coverage through Medi-Cal. So on the individual side for Cover California, on the individual exchange, again, if you don't have your employer group coverage, if you have income between 100% up to 400% federal poverty level, you can get some financial relief in either lowering your cost or lowering your premium. What does 400% federal poverty look like? That's for a family of 4, that's $95,000. So if you look at that, that's really not for poor people. It's just a way to incentivize people to take action to actually enroll in Cover California so that more people are in the insurance pool. The problem with uninsured and not having people in the insurance pool is that if everyone doesn't play in the pool, then we all pay for it regardless of whether or not they're paying their premiums. So there's incentives to try to get people covered, whether it's employer group, Medi-Cal, or individual.
Thank you. To kind of carry on with some of the incentives from the individual side, and going along to question of is it only for poorer people. There are some incentives for individuals, and the government is allowing some help in paying the premiums. And it starts as low as with income as low as 100% of the poverty line, which is basically $11,000, all the way up to like a family of 4 with household income of roughly around $95,000. And so if someone is required to buy health insurance, then there is some incentives there to help them. So it does cover a broad range of income levels there. And same thing on the business side, where we're seeing a lot of the larger companies do offer insurance, but for the smaller companies, yes, they're required to offer insurance now, but same thing, there are also some incentives there to help them with those fees and the additional cost of it. So hopefully later tonight we can talk some more about some of those.
I just want to reiterate what they just said, is that this is certainly not designed for the poor. And what's interesting is when you look at the statistics, the top 10 states in the country that have the highest percentage of uninsured, 3 of those states, California, by the way, is one of the leaders, Texas, New Mexico, they make up a third of that. You see the Southwest, interestingly enough, has got the highest number of uninsured percentage of any other area of the country. And it's really a sad statement to see that. And the numbers that come into a pool of insured then keep the premiums down. So really getting the uninsured insured as much as possible in a cost-effective way is really what the end game is. And coming from a state like Arizona, where I see that they've opted for the federal exchange, you can see how well that's working. You're quite lucky to have the option that you have here.
Let me pick this mic up so that Mike can. I think overall, it's not meant for the poor only, certainly not. But I would just add there that there are a lot of uninsured that cannot afford medical care today, and they will be able to buy medical care. So somebody making anywhere from family income from 23,000 to 93,400, some number, 400% of your federal poverty level. Somebody making $93,000 in most of the country may be okay, but really in Northern California, $93,000 is poverty level, right? And you a family of four, and to be able to buy for medical insurance, let's say somebody making $40,000 a year can buy something for $200 a month, is very affordable care. Having said that, it's not only for the poor. Unless everyone participates in the pool, we can't share the risk. So if you look at insurance in general, when the the Spaniards used to loot the boats of the lords of London, and one ship would get robbed, and he'd say, I'm bankrupt now. So why don't we all lords get together, and we'll all share the pool. So all these very wealthy, very rich boat owners got together and said, we'll all share the wealth. So if your boat gets stolen, we'll all share the loot together. We'll share it together, so you're lost. And that's how insurance was really created. The story goes there, or was it the Arab caftans that were robbed? One of the two. Who knows what the truth is? But the idea is it was actually meant for the rich. And this is what, if everybody, all the rich participated in that. Now, why did the rich not participate? Is because the rich probably ate a lot of food like I do, and I'm not ready for that, excessive food and get cholesterol and couldn't buy insurance. So I think that's the barrier where it breaks it. Mike back here.
Good. Darlene, specifically to you, and maybe anybody else that actually has more insight, give us an enlightenment into how does the tax credit work?
Sure.
Does the group have to qualify or enroll into the program by January 1st, 2014 in order to qualify? What are the ramifications of the tax credit?
Okay, sure. So keep in mind that the, whoops.
So,
It's
Is it on? Okay. Keep in mind that the credit, the small employer business credit, has been around since 2010, but there are some changes that take effect as of 2014. So the idea of the credit is that it's based on the number of employees you have and their wages. So for, it's basically, except for small employers, so employers with 25 or fewer employees and with average wages of those employees less than 50,000. Once you reach over 10 employees and wages over 25,000, the credit starts to phase out. So for 2010 through 2013, the credit, there's a couple different rates, but more or less it's 35% of the premiums that you pay for your employees. In 2014, it jumps up to 50% of the premiums that you pay for your employees. And so for 2014 as well, you have to buy the insurance through covered, through Sean, through the shop in order for it to qualify. And so, and then as far to answer the question, you have to have it as of 1/1/14. The way I understand the rule is that it's based on the premiums paid. So if you don't start paying premiums until sometime in March, then your credit's going to be calculated based on the premiums that you pay for those 10 months from March through December, so to say. So I believe you're still eligible for the credit even if you don't sign up as of 1/1/14.
So absolutely, the way to get the credit is through the shop. And I've seen regulation from the IRS that actually stated as long as you buy it sometime in 2014 on your renewal date. So a lot of companies don't renew January 1st, right? So you might have a renewal policy in January or February, March, April. But the IRS reg that I did read said that as long as you got into the shop on your renewal date, you would actually get credit for all the insurance premium that you paid as long as you qualified for it. So that's just a little bit of a qualification. The other thing that I wanted to mention is a lot of people go, $50,000 is average wage? You know, we're living in Silicon Valley. The average wage in Santa Clara County is $92,000. That's the average. But there are a lot of lower income people that actually do work for companies, and when you do that calculation, the owners, spouses, dependents, partners are all taken out of the equation. So there's actually 350,000 small businesses in the state of California that will qualify for some type of credit. And of those, 170,000 will qualify for the maximum 50% credit. So you'd be surprised that a lot more companies do actually qualify for that when you start taking out some of those higher income levels out of those smaller businesses. Okay. And I definitely talk to your agent and your tax consultant regarding that kind of stuff.
Just want to plug that in because I think many people talk about tax credit. There are 2 credits you get. So when you write your expense, your medical expense currently, when you pay your premiums to your insurance company, you show that on your Schedule C as an expense. That will continue for all, whether you buy it through the Covered California or not. So that will continue. This is an additional tax credit. There are many companies that have been participating in plans since 2010, and if you talk to your tax accountant, because you should have got credit last year and the year before and so on, if your average income is less than 50, and you might want to elaborate, because people don't realize that's a separate, you get payroll credit. So what you're paying into your payroll taxes, you get credit on that. So it's cash coming into your pocket.
It's a payroll piece for the tax exempt entities. For the for-profit entities, it will be a credit to offset your tax and your AMT tax. A couple things is that you do still get to deduct your premiums that you pay, but to the extent you take the credit, you have to reduce that. But a credit is always worth more than a deduction. And also, as Zain's saying, that if you have been paying health insurance since 2010 for your employees, and as Sean was mentioning that you pull out the owner's wages and the family member's wages, it's possible that you could qualify, that you can still go back and get those credits. The credit, you're able to carry it back for a year and then forward for 20 years. So it's something that if you can't use it in the current year, but there's additional benefits that can be used going forward on it.
It's like the Tesla credits. So Sean, when your site is up or it's not, I don't think it's down for maintenance all the time, right?
No, we're good.
No. Okay. So how does one actually go about enrolling in SHOP?
Sure. So with the SHOP platform right now with Covered California, we're looking to launch that enrollment process in about a week.
Okay.
So that's for.
And you're prepared for that?
I'm supposed to do I'm going up to Sacramento to do UAT testing, if anybody wants to join me and be a data programmer for a couple of days. So no, the individual site is up and running. You're able to apply online and enroll for coverage right now for the individuals. For the groups right now, you can do it numerous ways. You can do paper applications just like the standard industry does now with paper applications for each employee and the employer, or in about a week and a half, I'm not going to give you a specific date, it should be up and running for us to enroll small businesses on the line online as well. So you can have your choice, whether you want to do a paper traditional or go online.
So actually carrying on to that, what carriers and plans are currently on the SHOP?
Sure. So we've got on the SHOP, so there's two different sides of this. You have the individual side that's got, I think it's 11 carriers. It was 12, but we got 11. They're up and down the state of California. In the SHOP, we've got 6 carriers. One of them's Larry's company, Chinese Community Health Plan, that handles San Francisco and parts of San Mateo. The other carriers include Kaiser, HealthNet, Blue Shield, Sharp, which is a medical carrier based down in San Diego, and Western Health Advantage, which is based in the Sacramento-Davis area that handles up into Sonoma and Marin. So there's 6 different options depending on where your company is. In Santa Clara County, you would have access to Kaiser, Blue Shield, and HealthNet. San Mateo, you would add in Chinese Community, and other parts of the state, you'd have to find out who's your carrier. So, but we do have 6 options statewide. Most areas have about 3 to 4 options.
And how does one decide what is right for them?
So there's, Larry mentioned earlier, there's 4 different metallic plan levels inside the SHOP. You've got platinum, gold, silver, and bronze. So what you would do as an employer is you pick one of the different tiers, and within that tier, your employees would pick any of the silver carriers. So maybe you'd have a Kaiser HMO plan in the silver tier, a Blue Shield HMO, a HealthNet PPO, and a Chinese Community Health Plan HMO in the silver tier. So as long as you pick silver, any of your employees can pick any of those different plans that are in the silver tier. So that's up and down the tier levels depending on which tier you would like to purchase for your employees.
Great, I thought California was gonna add diamond too.
There's tin, but we didn't think that would go over too well.
But Zain, really, if you can throw some light from the broker side of the community in terms of how is that community actually interacting with individuals or with groups to help them decide what might be right for them. What is that process?
Sure.
And how does that process work?
Sure, so first of all, if you look around the room, I bet you if I asked everybody in this room, and I know quite a few that I've insured over the years or do insure right now, I bet you after we've done a great job of selling them the plan, they probably didn't understand half of it at the end of the year, right? What this tier is called is these metal tiers. At least standardize it, so instead of seeing 300 choices, you've got 4 to 6 choices to look at. I think that's a phenomenal job. Of all the things that we hear bad rap about Obamacare, when I first saw it, I told everybody, and I think I've got here and there, and I said, this is a great thing. This is really a great thing because it'll make it easy. Let me tell you where we would be slightly different than covered California.
Before we go into that.
Yeah.
A quick question. Between all these metals, physically I know the difference between them, but from a health plan perspective,
Yes.
what are the fundamental differences?
Sure.
I mean, with one, do I basically get barred from seeing the doc, or do I still get to see the doc?
Right.
Or do I see a nurse instead?
Right. So first of all, and I think you probably take the power away from me. It should be Sean should be answering it. Essential health benefits. So some things that you must have in a plan are going to be in all the plans now. Not only in the covered California or the exchanges, but also outside. So Blue Cross of California, United HealthCare, Aetna, all these people that sell group medical insurance, or Sea Change, the new carrier in town right now, considered the most hottest in the Silicon Valley. All these plans will have to carry these essential health benefits. On top of that, what happens is, it's very when I show you 7 different plans called, let's say, option 1 or Blue Cross so-and-so plan, you really, as a layman, would not know where they fall. So I think that's a great idea, whoever came up with, and it wasn't me. Bronze, silver, gold, platinum. Easy to understand, isn't it?
Must have been a lady somewhere.
Must have been a lady somewhere. But really, and what it means is really, bronze will be less than platinum, right? So that, or gold. So, and what do they cover and not? So the things that you look out for is your stop loss. Stop loss means after which amount I don't have to be burdened with more bills any more than I should. Stop loss is what you want to look at. And so the 3 things as a broker I advise my customers to look at is you look at your premium cost, add up your stop loss to it, and say this is the maximum I'll pay in the year. And that gives you a good nutshell of what you'll be end up getting. Because now essential health benefits are going to cover everything. Previously, there was a plan, and I won't mention the carrier, first degree burns were limited to only $25,000. Now, if you get a first degree burn, and your face is burned up, the ambulance that takes you up to Good Sam Hospital will be $25,000. Right, so these things are gone now, hidden things. Sean, you might want to throw some light on that, or Lou, you can.
Yeah, actually, let me add a little color to it, because the metal tiers were designated at the federal level because, for the reasons that Zain talked about, how do you compare a $5 copay plan from another one that might say $5? Because you really don't know how much your exposure is going to be on average, and how much the health plan is going to pick up on average. So in the wisdom of the design of the Affordable Care Act, they said, number one, you need to cover all these essential health benefits. So the federal law actually designated 10 categories. And each state then needs to adopt sort of a benchmark set of services that's going to be their essential health benefits. Being California, we added a whole slew of them. So every health plan that's deemed qualified health plan going forward in 2014 is actually going to be based on the Kaiser small group health plan coverage. So every service that was covered in that plan, plus the federal categories, plus a lot of things, service-wise, are going to be covered. So you don't have to worry about that. It takes the guesswork out of that. So that's number one. Number two, then, in terms of the metallic tiers, bronze, on average, the health plan covers 60% of the costs. You can anticipate paying 40% of the out-of-pocket costs. and it goes all the way, in 10% increments all the way to platinum, which is the richest, covers about, the health plan picks up about 90% on average of the cost, and consumer picks up about 10% of the cost. Now, there are so many different ways actuarially to get that number. I mean, I'll tell you, that's the game that we all play in insurance health plans. It's no secret, we just do this to whatever our advantage is. So Cover California during the bid process did a smart thing. They said, you know what, we as a selective purchaser will define what those benefits look like and what those cost sharing levels are going to be. And so they had a group of actuaries, I'm assuming, get into a room and said, you know what, for the silver plan, we're going to have a $45 copay, $65 for specialists. And the other important thing they did was they tried to retain that design, whether it's on the shop exchange or the individual exchange, so that if you feel cheated because you're on the individual side, you actually get the same standard benefits that the employer groups get. So they really try to make it then about, so all the essential services are covered, all the metallic levels are covered, every plan that participates in the exchange has to have one plan in every level. So if the copay plan at the platinum level is standardized between Kaiser, Anthem, Blue Shield, Health, and little guys like us, then you can compare apples to apples. So I think that was a good move on their part.
So one take-home message for me, guys, don't let your spouses decide on which plan to go. Seriously, I mean, you guys are going to end up with platinum or gold, at least, right? Anyway, so Zain, again, a question back to you. Do the brokers have to be involved? I mean, in helping individuals or groups select, or can they actually just go on themselves and basically decide to do it?
I think, again, they thought it out right, and I knew it a long time back, right? So the brokers, you need to be certified with Covered California. For example, I'd have to sit in a whole day class, getting bored there, and then I had to go 18 hours and do a test on which I passed.
I've only sat in 10 of them classes.
But I think it's a required thing, so that you're educated on that. So you can work with the broker, or you can go directly and buy the individual plans from the exchanges themselves. However, for individuals, you can also go buy it through enrollees. Whereas as for the group plan, the shop plan, you'd have to go to the broker. Now, a broker brings in a little better angle in the sense that I would go and shop not only the shop, but shop the rest of the market. So depending on what your situation is, United Healthcare may have a better fit for your demographic group. And so a broker has the ability, as long as the broker is certified to be able to represent shop. And not all brokers, I believe you said 3,000 in California?
6,000 now.
6,000 brokers in California are certified. But I think there are about 20 or 30,000 insurance brokers in California.
Oh, more than that.
Yeah, more than that. So you got about a very small percent that are certified. We by themselves, we're certified. I'm certified in 39 states, which is a lot of states.
Oh, you do a lot of traveling.
No, I had to do a lot of finger typing.
Online.
I had to do a lot of online stuff, and some we have to do tests. In Colorado, I had to go and do a test in some other states. Correctly. So a broker will bring more to that group that doesn't completely understand it. I'm not taking anything away from Covered California. I think the way the plans have been designed is very easy to understand right now, and you can. But I think there are other things that the broker may be able to add value to it.
Yeah, and from our perspective from Covered California is we think it's a great idea to use your licensed insurance agent. They're your partner in this, explaining the different plans, helping you choose what's out there. And like Zain said, we're not the only option. We're another option for you. Hopefully it's a good fit for you. It might not be. If you've got a different demographic of a group that might be a better fit for something that's outside the exchange, great. We don't want to take over the marketplace. We want to give you an option that's going to help you and your employees. So we would highly recommend on an individual or a group, talk to your licensed insurance agent. They're professionals and they can walk you through the process.
I know I have still a lot of questions, but I'm sure that you guys are bubbling with a bunch of questions as well, right? So why don't we start from left to right or right to left? Let me hand over a mic to you. We've got plenty over here to go around. And please raise your hands up if you guys want to ask some questions.
You just mentioned that you can take advantage of going to a broker. Is there a price point different? Does the HealthNet pay broker for
Right.
engaging them and
Great
sharing
question.
knowledge?
Yeah, great question. So, if you guys, I think you probably all heard it, but does it cost more to use an agent or an insurance agent versus not? No, the prices are the same, whether you use an insurance agent on the individual or not, as well as the group. So the prices are gonna be the same. If it's gonna cost the same, take advantage of their services because they're professionals and they know the industry pretty well.
I just want to add there, and no broker is any different either. So if you buy from one broker or another, you'll get the same price. It's all regulated. The rates are fixed. You can't negotiate on that.
Yeah, I was gonna add that on the rating side, the rate you see in the exchange, let's say it's too confusing, you don't wanna deal with that, it's the same exact rate outside the exchange.
Question. This is a community of entrepreneurs, so question to all of you. What are the entrepreneurial opportunities resulting from this shift?
Let me take that shot. I'm on my new company, which is Upmatic, and we're going to be changing the way. We're going to introduce a website where you can get the shop, you can get the exchanges, and those outside exchanges, individuals, everything by just entering one little bit of information in code. It's an industry created. I think this is a great opportunity for entrepreneurs, South Asians that know technology. I think there's so much. I mean, look at what the mess that's out there. You got so much opportunity. Just knock on the door and think of a little while, and there's lots of opportunity created here. 100 million Americans in my books, I think. 47 million Americans that are uninsured. Another 27 million that we think, for example, United Healthcare and Aetna are not offering individual medical plans currently in the state of California and some other states. So there's about 27 million Americans that'll be losing coverage from their current carrier, so they have to change. Then you have another, Walgreens is doing a private exchange, and other people are doing, other large companies are doing private exchange. They're going to lose coverage. So there's about 100 million, 1/3 of Americans, a huge population of Americans that'll be looking for medical care. There's opportunity out there.
Right. And let me just add, briefly, I think from my perspective, sitting on the sidelines, I'm not like these guys that are actually literally within the industry looking at the outside. I see a whole number of companies that are at this point in time reveling in the fact that healthcare is undergoing this shift, both from a delivery perspective. So believe it or not, physicians are beginning to also innovate in terms of how they provide care or structure their offices to be more efficient, or take care of the community of patients that they're now responsible for. I used to joke in the past and say that my pet dog, got better care than I did. Right? Literally. I mean, we would get a reminder from our vet for a vaccine that she had missed, right? I never got a reminder for a drug that I was on, right? I mean, they could care less whether my lipid levels were high or not. But now they're going to be, and they're innovating by basically buying more and more tools to basically mine their data. So lots of opportunities on the delivery side. I think more so there's a lot more opportunities that are emerging. Just yesterday in the Thai Angels meeting, at the steering committee meeting, there were two companies out there that basically were in the price transparency realm, meaning mining big data that is actually now beginning to get more accessible and more digitized, mining that data to provide more guidance to consumers in terms of one of the companies, Oration, is in the business of literally helping you understand where you could get a cheaper drug, for that refill. Make your deductible go that much more further. So if you're going to basically be on a deductible plan of let's say $2,000, then you're going to be out of pocket. Well, how can you make that $2,000 go as far as possible for the healthcare? You can switch that off. That was my mom and dad. With your gray hair, you still get reminded by them. But no, really, the bottom line is there's a lot of opportunities for entrepreneurs, both from the perspective of consumer empowerment, as well as delivery, as well as administration. I think the administration of healthcare, so if anybody didn't know this, out of every healthcare dollar, the 27% of our GDP, or $2.7 trillion that is spent on healthcare, approximately 40% of that is on administrative overhead. it doesn't go to patient care. If we can take even 10%, 20% of that out, believe it or not, we'll be bankrupt a little bit later. We're still going to get bankrupt, irrespective because of healthcare, but we'll at least delay, just like global warming, right?
So, just one other quick point on that, especially entrepreneurs, startups. You know, what we're trying to do in the shop is actually help you retain your employees by offering you a plan that's going to give you choice, like the big companies do. So the big, I don't know, Googlies, those kind of companies, they offer their employees multiple carriers or different plans, different choice. That's what we're trying to help is with our purchasing powers, bring the negotiations down, just like a large employer would negotiate with their carrier. So that's one of the other things we're hoping to help you as small businesses is retain and hire employees that are used to those kind of benefits on the large group side.
Yeah, actually, I love your question in terms of where is there space for innovation and entrepreneurs. So think about the fact that healthcare industry is about 20% of our GDP, which is a pretty big number. In the state of California, which is pretty big, you only have 11 plans on individual exchange, and then you have about 6 on the shop exchange. So in this industry, we jokingly say shift happens. And these are big data interfaces between Cover California getting an interface of information to health plans, plural, that tie in financial information that have validation to another source. And then we need to figure out a way to make sure they're in the system, pay to brokers, pay the IRS, pay the state, pay the feds of tax. Make sure that our data is uploaded on a server to do risk adjustment, reinsurance, and risk corridors. So there's a lot of moving parts in the exchange and also in health plans. We need to provide transparency tools to consumers. In California, consumers are not just speaking English anymore. So there's localization needs. There's all kinds of things where there's a lot of moving parts. And that's where I think innovation and entrepreneurs can take a piece of the pie. I think there's when you start getting big blocks, I think there's room for big blocks for innovation, and we'll see some things emerge.
Hi. Obamacare, I think we talked all about coverage, but the other aspect of actually cutting back the cost, and ACO is one of the models that suggested.
Yeah.
How is that working out so far? I mean, what's happening in that front at all?
I'll speak on sort of our own delivery system. As I mentioned, we're a combination of a hospital, an IPA, excuse me, and a health plan. And we have joint risk sharing among the 3 parties on multiple lines of business. So by definition, that's an ACO. We are not an ACO by the new definition that's in the federal government for the Medicare ACOs or the commercial ACOs, because on the Medicare side, it's called shared savings. And the shared savings are you get a gain or a loss based on how much you can bend the curve. We're actually on the low end, so we'd actually probably, but on the commercial side, the tricky part about it, marketing an ACO, typically that's not for smaller employers, which is again why in California a lot of folks are going to go to a shop that's 1 to 50, but it's the larger employer groups that have a lot more leverage and purchasing power are using or purchasing through ACOs because they want some performance guarantees and gain sharing. So that's a different financial model. It's an innovation. The tricky part to the health insurance world is that in California, for example, whatever you offer for one small employer group, you have to offer for all. So you can't kind of pick and choose what those partnerships look like and those gain sharing arrangements look like for small groups. So you can't do that. So really, it's for the larger employer groups where that makes a big difference. There is a pickup on that in California. A lot of folks here market that because it is sort of the new mode of the day. But at the end of the day, a lot of the medical groups really see it as, well, it's just capitation, which is what we've had in California. So we're a very mature model. If you're on something, if Kaiser jumps on it, they're not jumping on ACO.
Let me add, the way that I like to look at it, literally the ACO is accountable care, or whatever model that you want to call it. is finally pushing the burden on top of the healthcare providers to provide more efficient care in a better way, right, to the consumer. I think it's still yet too early to begin to talk about whether the model is going to work, succeed, is it going to benefit them or not, or is it going to benefit the consumer. I think the overall philosophy is that is the right thing to do. 5 years from now, 10 years from now, I think we'll finally begin to have at least enough data to be able to say whether this is actually going to work out for us. I think in principle, I can tell you that it's already having an impact. I mean, today, diabetics, I mean, you talk about entrepreneurs, there are already a number of companies that are coming out and number of health plans that are actually covering solutions and tools to better provide consumer patient engagement for patients that are, for example, suffering from diseases like diabetes that are a big high-cost burden to health plans and the like. So we'll see more and more of that, but still too early to actually talk about successes of the model.
Thank you everyone for the enlightening panel discussion. So I have a question. There's a lot of talk about, under the new Obamacare plan, a healthy person might end up paying a little more than what he or she was paying before Obamacare. Will that in any way impact people who as individuals don't want to, if they feel, okay, I'm going to be paying double of what I was paying per month, and with the penalty for the mandate being so, like $100 or something like that, so it's very low. I would have personally preferred a much higher penalty because I believe that healthcare should be mandated, but that's my personal opinion. Do you think that people might just opt out and just sit on the sidelines because of this particular loophole, if I can put it that way? Thank you.
Actually, Michael, why don't you take that?
That's an interesting question. But I have to go back to the technology question really quickly, and I will address yours. Because I was going to say something and I thought, no, maybe I won't, but maybe I will. In the white space right now that's created is in gathering information that can affect outcomes. It's technology that allows the consumer to effectively connect with a provider. It's technology that gives the consumer an opportunity to shop through either online, mobile technology, to be able to access services, and perhaps even pay for them. So you think about this, there's a whole marketplace now that's created because of this. And now the consumers are looking for it. And the health insurance companies are reluctant to invest the money in that kind of technology. Because the money they spend is in processing claims. That's what they do. They're not technology companies. So on the other side of the coin, when you're talking about, it's one of those that people may sit on the sidelines. Right now, I think the consumers are confused. By and large, they don't know what to do. And from the employer's perspective, you're wondering what you should do. And I guess I come back to you with this, is that you can choose to sit on the sidelines and then let things happen, or you can really look at this as an opportunity to participate in a monumental shifting of how healthcare is experienced and delivered. And I really think it's up to you all and your employees, and the decisions you make will really determine the success of the outcome of this shift in healthcare. And it's dramatic. It's been 20 years in the making. In California, you've been way ahead of the curve because 20 years ago, you actually started creating a marketplace to shop. And now you're experiencing an opportunity to really create, to participate in a marketplace that provides you more choice, but simpler solutions. So I say to you, it's really up to you. If you sit on the sidelines, you can let things happen. If you participate and actually start having a voice in it and start learning how to use this to your advantage and your employees' advantage, because I mentioned before, the most valuable resource you have besides your intellectual property are the employees that work with you, not for you, work with you. So.
the way that I like to say it, to be honest with you. You guys have all heard of crowdfunding. Well, crowdfund your own healthcare. The bigger you make this, the lesser will be that cost that you're talking about. Yes, in the beginning, the costs might be higher, but if in principle all of this works out and the crowds do join, you're going to provide a far more equitable system that will benefit a larger pool of people collectively. And irrespective, believe it or not, there's no free ride, okay? There's nothing that comes for free in life. We gotta pay up one way or the other, whether it's a penalty for you to sit on the side or whether it's through the taxes, we all have to pay our own share of this because we created it, irrespective. Now we're trying to basically rectify at least the delivery component of it and make it better. So crowdfunding, that's the way that I introduced it.
Actually, I just want to, I love your question. Can you tell I love this stuff? So let me explain.
Deploying.
Yeah, I mean, I've actually worked for 6 different health plans, and I, aside from business development, I actually do a lot of rate setting work. But it's a very interesting question. Younger, healthier folks may and will likely have a significant increase, and let me tell you why. Prior to the ACA, health plans set their own age ratios, whatever they like. So let's say a ratio, for the youngest employee or youngest person under 30 would be $100, and then the most expensive one might be $700. So that's a ratio of 7 to 1. Okay. Another health plan might do 5 to 1. Okay. The Affordable Care Act, the architects of that said that's just wrong. Why do we want to do that? It's not right, because why should the older folks have to pay so much, right? Okay, we kind of think we agree to that. So they wrote into the law this rule of 3 to 1. So the highest to the youngest cannot be greater than 3 to 1. Okay, that sounds about right. And in fact, the feds came up with this nice slopes for every age. You have a different increment. You go from whatever to whatever. So let's take the pre-ACA world where you have this ratio of 7 to 1. So let's say it's the under 30 has a ratio of $100 to someone else's $700. So let's say you have a rate trend increase of 6%, which by the way is impossible because everything went double digits. But let's just for argument's sake that it went up 6%. So now the highest rate is going to be $750 and the youngest is $250. So if you paid $100 and now you're paying $250, that's a big rate increase. Okay, but wait, there's more. So a lot of the younger folks, their incomes are typically lower than all the other folks who are higher income. So because of what they make, they'll get some tax break.
Right.
But they have to go into the exchange. So, but to answer your question, okay, why don't I just pay that 95? I'm out. This is too confusing. $95 or 1% of my adjusted gross income. I'm good. I can pay that. The issue is not the penalty. The issue is, you can only join the health plan during certain periods of time, and it happens once a year. So you can't predict whether or not you're going to need drugs. You're going to get into an accident. You're going to have an emergency sprain an ankle. What you thought you saved in premiums are eaten up by what you're going to have to pay that ER, that ambulance, that doctor, or those drugs that you need to. And then forget about follow-up care. So those are the things that the Young Invincibles. It's young and invincible because their parents are taking their care of coverage. But it's really peace of mind. You don't know what diagnosis or illness you're going to have, and there's some financial incentives out there for you to make it more affordable.
One thing you didn't mention, a big hazard, but especially the younger group, is TUI, texting under the influence. That will kill you faster than DUI.
One more thing to answer your question, I think, is that it's 1%, right? It's 95 or 1%. The rich will not care, will buy it anyway because they'll want to see if you get hospitalized, they'll come after you money. The poor get subsidy. So I think the participation will be a little higher than we are anticipating. Because if you're not making that income, you're getting it almost free, why wouldn't you participate?
Yeah, they've actually done some studies for the Young Invincibles, those that given the opportunity to buy it, they actually would buy it, but a lot of them haven't had that opportunity. So, it's hard to say, we can't predict the future, but there's some good signs going forward.
And I think the tax credits actually do help. And a lot of people are not understanding the implications of all of the tax credits that actually come in play.
And I think the penalty goes up to, what, 2.5% in year 3 of your income? So it could start taking a pretty good bite out of your paycheck.
So by the way, we've heard a lot from the right-hand side of the room. How about in the middle and on the left?
My question is a consumer question, and possibly you guys already covered it, but I had too much wine, so I don't know. How pre-existing conditions will be reflected in this metal levels? And besides the fact that exchange the shop, is there any protection from these small print situations on pre-existing conditions?
Small print?
Well, you know how...
The little disclaimers down at the bottom?
Right, that usually...
The magnifying glass?
Yeah.
That's what the vision plan is.
The vision plan, yes. So one of the things that the ACA did inside and outside the exchange has eliminated pre-existing conditions starting January 1st. So anybody signing up for a plan, pre-existing conditions are no longer applicable. So if you've had some prior health conditions prior to January 1, it's guaranteed issue, nobody can be declined, and there's no pre-existing conditions for any past conditions you might have had. So there's probably not as much room for those little tiny print.
In fact, if you look at the application, the individual, he just asks you for your name, your income to see if you get subsidy. That's all they're concerned about. They do ask you smoker, non-smoker, but that is not valid in California, so that doesn't change your rate in California.
Marijuana use?
Let's go to Colorado for that. So you really, there's no questions. Previously, if you filled out an individual application with Blue Cross of California or any one of these carriers, you fill out a 20-page questionnaire, then you get an email back saying, sorry, we can't take you because you'll run out of bills. None of that anymore.
So let me add on from a policy standpoint, an interesting thing, California chose not to use tobacco rating, which sounds odd because we're in California, right? I mean, it's illegal to smoke. They did that intentionally because smokers, if you raise the rate on smokers, what's going to happen to folks who see the rate? They might not get coverage, right? They might not want to pay extra. So Cover California in their wisdom said, you know what, we're not going to do that. I mean, a lot of us were public health folks and said, you know, this doesn't make any sense. They should pay their burden. But the important thing is, what's the goal? Get them covered. So that's why it's done that way.
I've got some fundamental questions, Amindra. 2 or 3 questions. The first is more pertaining to the ACA itself. So we've got this huge risk pool, which is about 40 million or so of uninsured. And it's not an even risk pool. So you've got certain risk pool, which is higher age, probably 35 plus and years of age, and then there's a lower. So what if in the current situation, you would have the higher risk pool actually signing on, and the lower risk pool, which is the younger generation, not actually signing on? So that's the first question. The second is, there's a whole lot of noise around the public exchanges, the state exchanges versus the private exchanges, and private exchanges are going to be offering probably more voluntary products or ancillary lines of products and stuff like that, and they're going to be advantages or disadvantages, we do not know. So some clarity around that. The third question is around the consumerism part of it. Currently we are having about 4 different tiers of plans. While if you look at the whole industry is actually moving towards more of a retail model. So you as an individual, a plan should be able to, or let's say anybody who's offering the insurance, should be able to customize the plan based on your specific needs and then kind of offer that. So are we able to actually achieve that in a tier, 4 model, between these? So just basic fundamental questions.
Sure, I already lost the first one.
The first one
I'm getting old, but
yeah,
I'm getting really, really old, but let's break your questions down.
The first one was about the 40 million uninsured. So you have a certain population which would actually go ahead and sign up, and let's say the higher risk pool actually goes ahead and sign up.
So hold it right there. So let's get that one off the bat first.
So we're hoping that doesn't happen, but there is some Larry probably has a lot more information on this as far as the risk sharing, and so inside and outside the exchange, if you're one of the carriers that's in the exchange and outside the exchange, there's actually going to be a pooling point and a risk adjustment that's going to help offset the anti-selection. So one of the problems that we had with the first exchange back in '94 with the HIPIC is there was a lot of anti-selection going on because of the plan level changes. You had a really rich plan and really inexpensive plans. What ended up happening is the really sick people went to the richest plans, caused those carriers to lose so much money they had nothing to do, but they had to leave. So there wasn't any kind of risk sharing, and that's one of the things they put into the new exchange, is to spread that burden of risk across the different carriers, whether inside or outside the exchange. So that's going to help. It's hard to predict the future as far as going down the line with
Yeah, so
everybody else.
the thing is, if all the 40 million sign up, then obviously you're spreading the risk. That kind of makes logical sense. But in a practical scenario, it might or might not happen, right?
I'll let the data scientists actually take that, but statistically, I can tell you that it will wash out. I mean, the numbers, those are really huge numbers, and irrespective, even if 10%, 15% of those folks sign up, believe it or not, it will normalize itself. And actually, I think that's literally what you're going to end up seeing.
Yeah, so it's actually designed to be a zero-sum game for selection. So if one health plan in a pool gets all the sickies and all the other folks didn't get as sick, the plans who attracted a healthier group actually has to pay into this pot, and the folks who attracted a higher acuity risk will actually draw from that pot. And so it's a zero-sum game, and you've got the state being a dealer. Actually, it's HHS. So that's the risk adjustment premise. It's a zero-sum game. Every health plan figures out, puts in a guesstimate on what that corridor is going to be, and we all accrue for it. And at the end of the cycle, we true up. They'll either come in and scoop it out of our money and put it into this pool, and those we'll take out. So that's the risk adjustment part of it. So that normalizes it a little bit. In the first 2 years in the exchange, there's also going to be this thing called risk corridor and reinsurance. And so based on what you thought your medical loss ratio was going to be if you're in certain corridors, you can recoup a certain percentage of about 80% or 60%, depending on which part of the corridor you're in. And that's federal dollars that they've set aside. And the third way is the reinsurance. So if your claims breach 60,000 per incident up to 250,000, then you get 80% back of that. And again, that's something that we're all funding into. But that's only on the exchange. The other thing in terms of risk is that the new law says that whatever you're pooling for risk for small groups, on or off the exchange, it gets pooled together. So if you think, okay, I'm going to get bad risk on the exchange, so I'm going to keep that separate from all my good, healthy folks out here that I've had for years and years, you can't do that by law. You need to pool them together, and you're rated accordingly. So I think I've covered the 3 R's.
Sure, go ahead.
The second question was around the public versus private exchanges.
Right. So that was my thinly veiled way of answering that. So on or off, so on the exchange, exchanges select the purchaser, they design the benefits. We pick the ones who want it by metal tier and say we're in, we're good. Makes it easy for everyone to compare. Off exchange and also private exchanges, and quite frankly, a lot of carriers who didn't go onto the exchange, they still need to participate in a risk adjustment if they're selling individual or a small group. But they have the freedom to design plans whichever way they want, so long as they satisfy bronze, silver, gold, platinum. So you still have a basis of comparison, but you don't have the tools and all the instruments that are in Cover California.
Yeah, I would agree with that. On the private side, they're going to be in their exchange, their private exchange, but they're not going to have any of this risk sharing or pooling. So they're going to have
tax credits.
And there's no tax credits, of course. They might have some ancillary coverages, and down the line, I imagine we will too on the public exchange. But that's something that we were more worried about ensuring the medical side of it, and that kind of stuff is probably going to come down the line. But I think we've got some advantages going there with what we've got going.
And I think on the last question that you had regarding the a la carte, I think, Zain, you were mentioning something about sea change, right? Maybe, that's a good model to maybe perhaps talk about.
I'm a lot younger than you, so I don't remember any of the questions.
So,
the third question was?
The third question was more around consumerism. Just very recently I attended another conference which was on Internet of Things, and how you would, the moment somebody gets onto the internet and does a search on Google, you would be able to understand his preferences and be able to, so I was just wondering, if we have just this tier 4 structure, which is your bronze and silver and those 4 aspects, are you really, driving consumerism? Because you've got to really understand their specific needs and then provide the right kind of plan or service or whatever.
Right. So really, your design structure of designing your own benefit package for your organization or your company. This afternoon, before I came here, I was at a meeting, and prior to that, there were 2 meetings, and I must tell you that they're still available where you can design products, your plan based on the way you want your demographics and your employee base and your income level of your employee base runs and what benefits you want to offer. They'll continue. All the shop is doing, and I don't know why we use the shop because it keeps marking. We should say all that Zain Jeewanjee Insurance is doing. You can market us. So I'm going to write a petition to change shop's name to ZJ something now. But shop,
California legislation.
yeah, I think so. So innovation. Where was that guy who said there's innovation? I think overall, I think there is an opportunity for you to sit down and design the plan that you want to offer to your employees. On an individual basis, I mean, there's not much to design. It's just what do you want to pay and what risk you want to take, and the 4 tiers give you enough choices on that. So I think there's going to be continued. And if your broker is not creative, you should talk to one that is.
I have a simple cash flow problem or question.
Everybody has a cash flow problem.
My daughter, she's interning right now, so she doesn't expect too much of income next year. So I was looking at, at covered California this evening, and I saw that the premium for this I guess it's a silver, $400 some, but there's a tax credit of like $190 or so. So that means the net premiums seem to be quite low, which is good. But my question is, will that come at the end of the year after she files for taxes, or will that be reflected in the monthly premium?
So,
you want to go?
yeah.
I was gonna say, she should have the option of how she wants to take advantage of that credit. She can either have it offset her premiums, or she can wait until she files her return.
Or she can pay the lower premium?
Yes.
Oh,
And then if there's any differential, it'll get made up when she files her return on a
Okay.
2014
So
return.
she, I mean, this is part of HealthNet, I guess, but she can actually pay the lower premium right now,
Yes.
rather than paying the full amount and waiting for the tax credit.
Yes.
Okay.
If for whatever reason she chose not to do that, she can pay the full premium and then we get the credit later.
Okay, thank you.
And how does that apply to co-payments?
Co-payments is different.
Co-payments,
Yeah, co-payments are different. So co-payments are at the time of your incident. and
Will
then-
stay the same?
Yeah, so there's actually 2 programs. And again, this is only individual exchange only. So individual exchange, you have the benefit of 2 programs. One's called the Advanced Premium Tax Credit. So Advanced Premium Tax Credit's on the premium. And so if you qualify between 100 to 400% federal poverty level, you get a sliding scale. So the lowest is, on the lower scale, the most you pay is out of your adjusted gross income is 2%. And on the higher end, it's 9.5% of your adjusted gross income. So based on that, and based on what your income level is within those brackets, that's your tax credit. So you can use that to apply to any of the plans in the exchange. That's one item. The other way that you can benefit from lower cost sharing is if you fall under 250% federal poverty, and there's a sliding scale that goes, the normal silver plan is about a $45 copay for a PCP. If you're on the lower end, like 150% or below, your copay can be as low as $3. So that's your cost sharing part of it versus your premium. So there's 2 things that go hand in hand, but that's only on silver.
So whoever thought of this was brilliant. So if you don't have money and you can't afford plans, not only do you pay a lower premium, but you also pay a lower utilization cost. Brilliant, brilliant.
Yeah.
And mind you, I mean,
And
This is
that's
just
coming
for
from an
my-
insurance agent.
this
I think it's brilliant.
is just for my clarification, and maybe Darlene or Lou. So aside from the tax credits, do I also get to offset any external out-of-pocket medical expenses? That's,
Yeah.
I think, where you were headed
Yes.
towards.
So that's, on the silver plan, as Larry was saying, if you fall below 250% of the federal poverty level, you actually can get a silver plan instead of a $45 copay, which is their average. You can get a plan that's like a $3 office visit Because as Zain was saying, if you can't afford the premium, how are you gonna afford a $45 copay, right? So, yeah, so they help, if you're under those levels, it helps offset those out-of-pocket costs.
Yeah, so if you can come to the Thai event for the dinner, you can afford that.
That's your copay.
So it looks like some of you mentioned that the idea is to cover everybody, so it's pool risk and everything. And what I'm trying to understand is, was there any thought given to minimizing the overall healthcare cost for everybody? I mean, looks like the healthy people are getting taxed. I mean, is there any incentive for staying healthy at all, or? I mean, we're going to go bankrupt no matter what, right? I mean, at least I can go bankrupt with less money.
So let me just clarify one thing. Look, we're spending a whole lot of money and we're not necessarily achieving what we want to achieve today, meaning that there are still a large amount of people that are literally uninsured. They're not even getting insurance coverage, right? With this, and at least for a period of time, it's supposed to be a zero-sum game, literally. I mean, meaning that we're not supposed to necessarily increase our costs. The idea is through this model, at least for a period of time, we're going to be decreasing those costs, or at least keep them at where they are, in relatively speaking, right? I'll give you an example of my former company, right? Every year, believe it or not, overall, I was spending about 8 to 9% of my annual budget on healthcare insurance. Every year, that insurance cost was going up by 15 to 20% in terms of premiums. And that is the reality of a lot of other companies, guys, okay? That's not any metrics that was separate only to my company. And it wasn't as if our plans were necessarily that rich, right? What we gotta basically figure out is, and what you're asking are perfectly the appropriate questions. Do the healthier literally get shafted in this game? I don't think so. And I don't think that is what will actually happen.
I mean, is there any incentive to stay healthy? I mean, people will, the insurance costs are low, so people.
Sorry, Zain, go ahead.
Yes, there is incentives to stay healthy, and you talked about Sea Change. Sea Change is a carrier that came into play a few years ago, and it's a California company, funded company. And what they do is, they discovered, and Obamacare actually does that too. They ask you to do preventive stuff. The reason is, I'll give you my own personal example. About 6 years ago, I was trying to go take some life insurance out, increase my life insurance. My insurance company rated me, which means they were going to charge me more than what the normal person at my age 6 years ago would have lived. And so I was panicky. I went to my cardiologist, who was also a good friend, doctor, and did a full checkup. Turned out my cholesterol was way high. My lifestyle changed that morning. Next morning, I live in my office is on a 6-story building, and I didn't take the elevator. I was running up the stairs. I started swimming every night. I eat more vegetables right now. Somebody's telling me, "Are you in a diet plan?" Was it Ramesh or somebody came up and said, "Are you in a diet plan?" No, my eating habits changed, and I totally changed. My weight didn't change, but my lifestyle, my cholesterol changed. So if everybody does those preventive stuff, they'll change. So Obama does that. Previously, nobody paid, you had to pay a copay for your preventive stuff. Now under Obamacare, you get all your preventive. So even if you take a high deductible plan, the high co-insurance, even if you take the broad, your preventive stuff is all covered at 100%. No copays or nothing. Over time, as Sanjay was saying, I mean, it'll take time. I would say 5 to 10 years, you'll see the American population looking like the European population, thin and healthy. And you'll see everybody eating properly because their health premiums are going up. Now, Sea Change, the carrier, what they do is you buy an insurance policy with them. They give you a $3,500 deductible. There's a $2,000 deductible. They ask you to do three things: a biometrics test, blood test, which they pay for, a physical exam, and a questionnaire. They won't change your rate or anything, but if you do those 3 items, they'll give you $500 towards you. They find out you have diabetes, they might send you diabetic equipment for free. So that is where the healthy get incentivized, right? If you're going to stay healthy, eventually. And trust me, right now the healthy people pay higher. Why? Because I'm healthy, I can buy insurance, I go to Good Sam Hospital and they bill me $490,000 for a 4-day stay. El Camino Medical Center, this is a number that came out about a year and a half ago for my partner was in El Camino Medical Center for 4 days. $490,000. I could stay at the Al Burj in Dubai at the penthouse for $27,000 a night. Right? So just get a perspective there, $497. Why? Because the unhealthy people that didn't buy insurance were attending that hospital at my expense. And that's where this game will change.
But what factor is that, if you don't mind me asking?
I'm
But what factor is that? Let's say you're talking about all unhealthy people, and we said 40 million in the US. But in the overall cost structure, what percentage is, how much costs are getting inflated because of this public?
Well, I don't know what the inflation cost, and I think Lou would be a better person in data center, not because he's in the center, not because he has all that data, but the data center. Lou, you want to take a shot at that? What is the percentage cost of?
Yeah, I'm not going to try to, I mean, I'll explain it from a business model. So a hospital has beds they need to fill, and they have a bottom line they need to meet. And what happens, excuse me, is that when they negotiate rates with every carrier in town, and some nationally, they have to figure out how much of the portion of their beds and their patient base is going to be coming from that source of revenue. And then they also know that Medicare and Medi-Cal is continuing to squeeze that rate down. So they still need to balance. So they have to come up with a rate for those folks who are dumb enough to basically not have insurance, to have someone negotiate that rate with them. So that's where you get the $400,000 bed. And this is why a lot of folks declare bankruptcy after they get hospitalized. So in terms of how that cost shifting plays in, it could be 40% of hospitals' bottom line. And what's going to happen is, again, with all these programs that are expanding, we want people to find these programs so that they're participating in a program, whether they're paying a premium in or not, so that there's less cost shifting going around. So if you think about it, if Medi-Cal is expanding, that's squeezing them down in another area. Medicare, because of the sequester, they took about 2% off the top. So that's going down. So guess what? It's going to get paid by commercial payers. So it doesn't matter how you squeeze the balloon, it's going to pop up somewhere. So that's the reality of it. It's not, the Affordable Care Act didn't say that it's going to make things cost less. But the question that he had, which I want to get back to, which is, okay, so is there an incentive for me to be healthy? Actually, the incentive, any way you look at it, there's really a hard business model to be made from the insurance side. Why? Because if I'm going to invest in your health to keep you healthy, how do I know that you're not going to go to HealthNet the next week? So my investment in your health and your wellness, gone, kaputs. If you drop out and you stay healthy, does anyone gain? The answer is no. So really, the business model for your own health is really your own health. It's not, is there a business model that a health plan or policymakers can put together to incentivize you to be healthy? That doesn't really work in the long term. The best we can do is control 15 months of claims, and that's how health plans look at it. Can we keep this person? Can we rate for 15 months of premium to make sure we cover this person's anticipated costs, not your wellness? So the preventive care benefit that Zain talked about is to prevent barriers from you accessing preventive care services and consultation with your doctor, so you keep on track with a lot of things.
Can I just add one thing? One thing that not many might know about that is affecting hospitals. Before the Affordable Care Act, for providing care to the uninsured or the unhealthy, as you might call it, or the one that cannot, the government was actually subsidizing that. At the end of the year, whatever, they could actually claim for some of all of that extra cost back. Right. That is going away. With all of this, now hospitals are not getting that because those folks are now supposed to be covered by health insurance, and they're supposed to be able to get care that they need. So literally, there's a shift overall on the different components and segments of the healthcare delivery chain that has to, this whole ecosystem is getting shifted. It has to, eventually rebalance and equilibrate itself. And it will take some time to do that.
And surgical centers, I think a lot of them moved away from the whole hospital model.
Sure.
Because of all this cost restriction. So I guess for some time, there was a restriction on opening any further surgical center. Is that opened up again now, or? Because, they're becoming profit centers, highly profitable compared to hospitals.
Sure. I mean, what you have seen mushroom up is actually, I think, more of the ancillary care environments that are supposed to basically provide for what I would call more triage-based need care, right? Urgent care centers and the like. Believe it or not, a lot of physician practices are now beginning to get gobbled up by the hospitals, right? Because it's better for them to basically be underneath that particular umbrella. Again, these are just shifts that again will basically tell us where things will basically move eventually. I cannot necessarily answer whether, having independent surgical centers is beneficial or not. Time will tell. Eventually those surgical centers, by the way, might be part of an ACO. Each and every delivery environment is supposed to be in that, right? But listen, I think we are literally out of time. We are about 5 minutes over. The panel will actually be available afterwards to basically network as well as to dialogue together with you guys. But really, I think the panel has been super. This has been a very, very engaging panel. I personally want to thank them for making the time. Thank you very much.
Thank you.